osmolality when we are dealing with hyperglycemic hyperosmolar state. So Akash, can you tell us if we have a patient of diabetic ketoacidosis versus hyperglycemic hyperosmolar state, which patient would have higher mortality? Higher mortality.
Hyperglycemic
hyperosmolar state would have a higher mortality, and the you should thrombotic episode has to be looked for. And urine ketones 1+, what does this signify?
The urine ketones, usually we only measure the acetate, sir.
So basically, it does not. It may be because the patient's malnourished patient is having. So 1+ does not signify the criteria for diabetic ketoacidosis. And obviously, we need to have other clinical plus other ABG parameters. Do we please? So pediatric resident, please. So if you have a type 1 diabetes and he has anemia, so what are the causes which you will come to your mind?
Sir, anemia.
Any other resident? Please, everyone should participate.
Malabsorption.
Which malabsorption? Which disease you're thinking of?
Celiac disease, sir. Autoimmune hemolysis can occur.
Please. So basically, it is autoimmune disease. So you look for other autoimmune diseases which may be present, and what are anemia-related diseases? Celiac disease, pernicious anemia, they can present. Again, Prashant, what are the causes of anemia in type 2 diabetes?
So a patient can be having diabetic nephropathy, sir, which will lead to a reduced erythropoietin level causing anemia, sir. Then patient can have anemia of chronic disease, bone marrow suppression because of the chronic inflammatory condition, sir. Then sir, patient can have gastropathy because of the diabetic gastropathy. Then sir, uremia can lead to blood loss anemia in the GI blood loss, sir, which can lead to an iron deficiency anemia, sir.
Any drugs can cause anemia?
Yes, sir. So metformin can lead to
Which what type of anemia? What metformin?
Sir, B12 deficiency, sir.
So metformin causes B12 deficiency. In fact, ADA tells us that every patient of metformin, we should consider to start patient on B12 therapy. And any other drug which you are aware, which patients are given, which can cause anemia? So basically, please sir. So antiplatelet at times are given because of higher cardiovascular risk factors like itosprin, which can lead to UGI bleeding. We have this question. Robin, you can answer. So you are basically young officer. In our perspective, we can take it. Serving personnel come to your OPD that he comes with this report: fasting of 109 and post 2 hour glucose of 91 milligram per deciliter. And he says, Dr. Saab, you reversed my report and please get this corrected. I'm not diabetic. So what advice will tell him? And you are sure that it is not wrong report.
Sir, this kind of a picture can happen, sir, if there are.
Has it happened with you?
Yes, sir.
Yeah, very good.
Sir, this kind of a picture can happen if there are some imbalance with the counter-regulatory hormones, sir, or if during fasting, sir, if there is no suppression of the gluconeogenesis or hepatic glucose output is not reduced, sir.
Sit. So basically, this is a very, very common scenario which we encounter in OPD practice, where patients walk in with this such abnormality and they say that the report is wrong, but actually it is always good. In fact, 109 is still lower. Patient can come with 115, 120 with a normal post 2 hour and they say my report has been reversed. And why does it happen? Because of the increased hepatic organ-specific glucose resistance, and there is the increased gluconeogenesis which happen. And also another explanation for this is that these patients are having impaired. So whenever the patient is onset of diabetes, first thing which happen is a impaired first phase insulin secretion. What is the first phase insulin in secretion? Any physiology resident? What is the first phase of insulin?
Sir, whenever there is increase in the blood glucose level, sir, so the glucose is basically, sir, be metabolized by the glucokinase, and in the initial phase, the glucose level is released at the rate, sir, 3 to 5 micrograms, sir, because the
How the duration of first phase of insulin?
So that is 0 to 30 minutes, sir.
Please. So what happens when even by the site of the food, there is a secretion of the insulin which lasts for only few minutes, and it is for the first phase of insulin. So whenever there is an onset of the diabetes, the first impairment which happens is an impaired first phase insulin. But the second phase is the prolonged secretion of the insulin which happens in response to the food intake. That is why you are able to control your postprandial glucose level, but your fasting becomes impaired with the combination of first phase insulin as well as a increased hepatic glucose because of organ-specific insulin resistance. So we also did ABG, which was not related to diabetic ketoacidosis, and ultrasound, including X-ray abdomen, was normal. And thyroid function, thyroid was low in this patient, and stool was better, which was normal because she had so died. So, Ashok, what is this?
This picture shows, sir, in erect abdomen X-ray, sir, there are multiple radio opaque opicities, sir. Mainly, sir, chronic calcific pancreatitis, sir.
Please, sir. So this is very important. Whenever we're dealing, we told you, we discussed in the starting that type 1, type 2, and the pancreatic diabetes are three kind of diabetes which leads us into the confusion of diagnosis diabetes. So pancreatic diabetes simply in an appropriate setting, X-ray abdomen may be good enough where you can pick up the pancreatic calcification. So if we have a radiology that's here. So what are imaging features of chronic pancreatitis?
For evaluation of chronic pancreatitis on USG, we can see the atrophy and fatty atrophy of the pancreas and ductal dilatation and pancreatic calcification. Same can be seen on CT scan, sir. So, these
What is this?
pre and post contrast, sir. These are showing, sir. This is the pancreatic. In the first image, sir, non-enhanced showing calcific pancreatitis, sir, interparenchymal calcification. In the second image, sir, we can see it's a post-contrast image, sir. We can see areas of non-enhanced areas which can be pseudocyst in the setting of chronic pancreatitis, or maybe some insulinoma which can be there, sir, because it's a small lesion, sir.
Very good. Basic pancreatic. Secondly. So basically, atrophic pancreas, dilated main pancreatic duct, and pancreatic calculi, ductal calculi are the features which would suggest. So what's a type 3C pancreatitis? Robin?
Sir, it is also known as brittle diabetes, sir. Pancreatic diabetes with exocrine endocrine insufficiency.
Please, sir. So pancreatic, the type 3C diabetes is very commonly is used as a term in the place of the pancreatic diabetes, but actually it is a misnomer, and we have to go through the history. So what happened is 2 decades back in WHO classification, so pancreatic diabetes was kept under the heading of 3 and subheading of C. So that, and some 2 researchers from England, they were doing a research on pancreatic diabetes. They wrote the term as type 3C, but actually it is not accepted terminology, and we stick to the pancreatic diabetes or diabetes of exocrine pancreas. So what is fibrocalcific pancreatitis? Sridhar.
So this is also a variant of exocrine pancreas insufficiency, sir, where we have diseases like cystic fibrosis causing diabetes.
Chronic tropical pancreatitis.
So, seen mostly in the tropical countries.
So basically, it is also called the tropical chronic pancreatitis, which is seen in the tropical countries, in economically little backward countries, and it is also being postulated, and that the cassava has been postulated in the causation of this, and it is also said that with even Indian states like Kerala, etc., maybe having where the cassava consumption is higher, maybe these states are having higher prevalence because of this cassava. But however, subsequently, this is not validated, it has not been proved. So what is happening is we need to differentiate this from the alcoholic and tropical chronic pancreatitis. So few pertinent features are, so tropical chronic pancreatitis basically have a diabetes prevalence as high as 90%. On the contrary, the alcoholic chronic pancreatitis would be having diabetes only 50%. There would be markedly higher incidence of pancreatic cancer in tropical chronic pancreatitis, and also the onset of tropical chronic pancreatitis would be in second and third decade. And from radiology point of view, it is important that more, distortion of architecture would be there in the tropical chronic pancreatitis. Large dense calculi, mainly in the larger duct, fibrosis and ductal dilatation may be present. So these 2 entities, we need to pick them up, because then management would be different, because we also know the tropical chronic pancreatitis may proceed to the pancreatic cancer also. So brittle diabetes is a term for the pancreatic diabetes, because these people are very difficult to control. Is the diabetic ketosis the norm in the pancreatic diabetes? Rajesh? Is diabetic ketosis the norm in the pancreatic diabetes? Yes or no?
Yes, sir.
No. So answer is no. Why? Because beta cell is also destroyed and alpha cell is also destroyed, because there is no high glucagon. So when the glucagon is a mandatory, counter regulatory hormone is a mandatory for production of the this ketoacidosis.
So with this, we diagnose the patient as case of type 2 diabetes mellitus with uncontrolled hyperglycemia with features of diabetic neuropathy, diabetic cachexia, and anemia. She was started on fluids, insulin infusion, and then switched to basal bolus regime. Her insulin was optimized based on sugar levels. She was started on high protein diet with micronutrient supplementation.
Indication of insulin type 2 diabetes. Anjana, Dr. Anjana.
Sir, uncontrolled hyperglycemia with HbA1c elevated, sir. And sir, excessive cachexia.
Please sit, please sit. You have a little idea. So what happens is, first thing to remember is any newly diagnosed diabetes and the patient is having HbA1c more than 10% and your glucose more than 300, please start the patient on insulin. Why do we do so? Because by giving the insulin, the glucotoxicity is broken, and this is the attempt by which we can do some kind of beta cell regeneration. And it has been seen that these patients land up into better glycemic or better, profile with respect to the complications in the longer term. And any patient will end up with emergencies, patient with gestational diabetes, patient who's having acute illness or undergoing surgery, please give insulin. And in the end, obviously, the patient who's progressing seriously from beyond the oral anti-diabetic drugs, they would require subsequently insulin. But what is I have highlighted here is our patient was in a catabolic state. Whenever a patient is in a catabolic state with advanced hyperglycemia, insulin is only a mode of therapy. So when we were doing attempt of classification of diabetes, it is important to remember that yes, that can be, you can do that later on also. You can keep the diabetes unclassified, but whenever situation, guides you, please treat the patient with the insulin in such a scenario and subsequently keep on making the effort. Till that time, keep the diagnosis open-ended as simply as diabetes. So this was the sugar profile. So what, Dr. Sheikh, what would you have done with this? What should we do? This was sugar profile of patient. So we can see now we wanted to fasting first we were telling. So what is the fasting range? So what do I do to my insulin?
Basal insulin will.
Okay. So now I did this again. We did something else, the sugar in the early morning. So what do we do now? So this is the addition. So the patient was having higher glucose level in the pre-breakfast, and the patient, we did a 3 AM glucose after certain discussions, and we got this value.
Maybe because of Somagai effect.
Very good. So Somagai effect is, so what is Somagai effect? Somagai effect is early morning. Please say good. So early morning hypoglycemia leads to secretion of the counter-regulatory hormones, and you can get a higher glucose when you do the pre-breakfast. So what is the clinical implication of it? Mostly what happens is, by just analyzing your pre-breakfast glucose, people keep on increasing the insulin level. But in such a scenario, what was required? Reduction of insulin was required, and that was done in this patient, and patient improved significantly. And similarly, this is a chart, CGM chart, which was subsequent for all the days, which we can see here. Again, there's a dip early morning and the rise of glucose, which is happening, and this is showing the Somagai effect, which is important to recognize because this would require reduction of the insulin. So Dr. Ram, so we have understood the green is Somagai effect, where there's a dip in the early morning. What is the red?
Red,
Red is the dawn phenomenon.
Good, please. So dawn phenomena means that if you check the 3 sugars, if you get a higher sugar, it means it is called a dawn. What does dawn means? Means because there is a growth hormone, cortisol, and counter-regulatory hormone which is secreted throughout the night, which have effect in the from a morning 4 to 8 AM. So they will cause your sugar to go high. In such a scenario, you can consider increasing your insulin previous night, or you can do the dietary modification during the dinner. So this is a dawn phenomenon.
So patient had optimal glycemic control with optimization of insulin. She gives history of dysuria with mild pain abdomen. Her urine culture showed E. coli, which responded to antibiotic. However, her ultrasound was normal. She had worsening of pain and paresthesias of lower limb following the initiation of insulin. Patient also remained depressed with low mood and was lonely when found in the ward.
So when it comes to the head and neck region, they are more prone to rhinocerebral mucormycosis. Along with in the skin, you will have staphylococcal infections like furunculosis or folliculitis. They are also prone to oral candidiasis as well as esophageal candidiasis. And